Yes, Nageshwara.
Yes, sir. Good evening, all. This is Dr. Nagesh Reddy, consultant medical oncologist in Speaker, Tata Cancer Care Foundation, Tirupati. I have two cases for today. One is prostate and the other is ovary. The first one is regarding a 78-year-old gentleman. He was diagnosed to have carcinoma of prostate with stage 4 with lung and liver metastasis in November 2016. And thereafter, he underwent, he did not have any comorbidities or significant family history, and he is well preserved with performance status of 1. Next slide, please. Then he was treated since then with EDT with continuous 3-monthly leuprolide, 22.5 mg. And then 6 cycles of docetaxel were given initially. The last one was in June 2017, followed by pelvic RT. Because of biochemical relapse, he was rechallenged with docetaxel with 4 cycles. That was till March 2020. And then at this point of time, he came to our hospital. And based on the biochemical values, it was around peak of COVID in 2020. He came to us, though he was advised PSMA PET CT, he couldn't undergo. Based on the PSA values, we have started him on abiraterone, and it worked fine for almost more than 2 years, almost 2.5 years. And then later on, PSMA got increased, then changed treatment to cabazitaxel for it was given for 6 cycles, but the disease was only stable after that, and then followed by enzalutamide. Enzalutamide resulted in a good PSA decrease for about more than a year. Then after that, he progressed. And this is the treatment history till now, and we have done a PSA trend for with abiraterone and enzalutamide. There was a good dip in the PSA values. The current PSA values are 113. We did a PSMA PET CT and advised for biopsy from the lung lesion, but the patient wasn't interested in undergoing tissue biopsy, so he had taken a second opinion and underwent liquid biopsy. Next slide, please. So these are the findings of liquid biopsy report. CDK12 mutation and then androgen receptor mutation. These are the mutations. I couldn't find any major data on these things. Now want to confirm what can be done further based on the report. Patient wasn't convinced for tissue biopsy report. Tissue biopsy.
Okay. Can we go to the NGS report? Yeah. You proceed. I think you have some more.
Yeah, I am done, sir. This is the regarding the case, and
Okay.
this is the NGS report, sir.
Okay. So the patient is having CDK12 frame shift deletion is there, and along with that there is another androgen receptor missense mutation is there. Both are VAF is that is 2.29%. This is androgen receptors is 4.91%.
Yes, sir, 4.91.
Okay.
And though we haven't, patient has not undergone bilateral orchidectomy, the testosterone is around 1 to 3 nanograms per ml. That is very much less than the castration level testosterone, which is 50 nanograms. It is around 1 to 3 nanograms per ml.
Okay. Tamal, can you go to the questions? What doctor has posted? Yes, just keep it here. Thank you, Nageshwaram. So this is a metastatic castration-resistant prostate cancer. So multiple levels of chemotherapy. I think 78-year-old. That is another thing which we should consider. And a liquid biopsy has been sent, and 2 mutations, probably predominant molecular pathway. Probably one is CDK12 loss of function mutation is there, which is frame shift mutation, and another is androgen receptor resistance mutation is there. This is the case. So probably 4 questions our presenter have is one is role of immunotherapy in this particular setting, any role of platinum, And should PARP inhibitor be considered? And clinical trial options for CDK12 mutated prostate cancer patients. Okay. Thank you, Nageshwar Rao. Let's get the opinion of experts. So who would like to start? Silambarasan is there. I think Aparna there is there. I'll post. What is my thoughts? I'll just tell so that people can start. I think one of the question why Dr. Nageshwar Reddy has posted this is because CDK12 is again is a DNA damage repair pathway. So and most of the prostate cancer, metastatic prostate cancer has seen HRR mutant as one of the subset where they tried PARP inhibitors. If you see the Propel study or Talpro study, all these things where they tried PARP inhibitors, they tried in HRR mutant particular subset. So CDK12 comes in that DNA damage repair pathway. So whether because of this pathway, whether PARP inhibitors and platinum-based chemotherapy will be more useful, that was the question. My thoughts for the question 2 and 3 is one is yes, as you rightly said, most of the studies, PARP inhibitor studies, has taken HRR mutant prostate cancer. But still, if you go into the subgroup analysis, main subgroup that benefited with this is BRCA2. So whatever the hazard ratio, what we got is the benefit was mainly from BRCA2 mutant patients. So how much the CDK12 patients will be benefited, I'm not really sure. That is point number one. And yes, if you see the even the disease-free interval for Taxol, docetaxel, and cabazitaxel is really good. I think the patient went on for 2 years after receiving chemotherapy. Yes, I think any role of platinum, yes, in this particular patient, weekly nab-taxol carbo, yes, definitely will be, I will consider in this particular patient. These are two of my thoughts for this cancer. Role of immunotherapy, I don't know. In this case, probably other MSI, TMB, probably was it done? Probably that can be seen. Otherwise, based on this NGS report, I'm not sure we will offer immunotherapy for this patient. Uh,
We thought of getting tissue biopsies, but
yeah.
he's not willing, sir.
So then I think the immunotherapy will not be of my choice unless
Yes,
we get
yes.
some TMB or MSI. Clinical trial options, yes, there are some good retrospective studies. If you go back, where CDK12 mutated, even I had some patients where CDK12 mutated particular patients, there are good retrospective studies where PARP inhibitors had good response. There is one retrospective study showed CDK12 mutated particular patients where Ipo-Nivo was tried, nivolumab plus ipilimumab. There was some 10 to 15% response, but all are retrospective and exploratory analysis. There is no prospective study as far as. So for your question, my thing is yes, weekly Taxol carbo, I will definitely consider because of the age. PARP inhibitors, already patient has tried abiraterone. See, we don't have much option. Probably abiraterone plus olaparib can be tried. So it can buy some more time. These are two options that is coming to my mind. So let us see other molecular experts what they are thinking. So anybody wants to give suggestions?
Hi, sir. Maybe I will go first, actually.
Yes.
Thank you, sir. Nagendra, sir. This is Dr. Silambarasan here.
Hi,
So
hi.
I
Yeah.
gone through the case briefly and collected some of the case reports for you. Maybe it will be useful, but we need to take it in the pinch of salt with a holistic approach. We need to analyze the data maybe in a depther manner. So CDK12 comes under the category of cell cycle gene, like CDK4, CDK6, and then CDK9 and CDK12 basically. So as of now, we don't have CDK12 inhibitors basically, but there are certain evidence like Sar have mentioned, patients may respond to the PARP inhibitor kind of therapies or platinum based kind of therapy response. So if you are asking very specifically immunotherapy, this is the one more thought process you can consider. Whenever you are considering immunotherapy as a single agent, it may not work. So you may thought about it immunotherapy with a combination of PARP inhibitor or with a combination of chemotherapy, like especially platinum-based chemotherapy. There is some case reports and case evidences are there, which I will share with you after the meeting through the things, so that we all can discuss on the same part of it whenever we are sending it out. So immunotherapy, if you want to try, only few case reports are there. We don't have any standard treatment options available. But even if you want to try immunotherapy, you need to go with a combination of either PARP inhibitor or chemo combination. So that's my take-home message for that. For this case.
One more thing is here re-challenging just abiraterone or enzalutamide or any other androgen blocker. I don't, because there is a resistant mutation. I think it may not work in this particular patient. You need to add PARP inhibitors along with probably AP androgen pathway inhibitors. Only androgen pathway inhibitors may not work because there is a resistant mutation that we need to take into consideration.
Sir, this also I want to add one more, sir, Arun, actually, sir.
Yes, sir.
This mutation, specifically that AR resistance mutation, not for all the androgen drugs, it is a resistance mechanism. Only
Okay.
2 drugs which we have tried in this treatment so far, exactly for those 2 treatment only this mutation is resistance. There are other 2 drugs that resistance mechanism can be overcome with that particular drug, which also I will share with you, sir. That exactly yesterday I have collected that information also. Yes, sir.
That's a good information, because this is a 78-year-old. Some
Correct,
point
correct.
of time, I think we are going to exhaust all chemotherapy options. So if you have molecule, which molecule will
Yes, sir.
work best with this resistant mutation,
Ah.
definitely it should be good input from you. Thanks, Dr. Salambarasan. Probably Nagesh
In
Rao.
another 5-10 minutes, I will share with you, sir. That paper also I have downloaded everything exactly. So this particular variant will be only resistance to one of the 2 PARP, this AR inhibitor. Other 2 AR inhibitor will not be resistant mechanism. Yes. So that I will
Okay.
share with you.
Okay.
Yeah, I think, thank you, sir. Thanks for the
This
your
patient,
submissions.
sir, good evening, sir. This patient, are we not considering a PSMA therapy?
Yeah,
Any
we
point of
have,
time?
yeah, there is we have taken the nuclear medicine opinion. They suggested to undergo FDG PET as well to check the FDG uptake. And PSMA uptake is there. I think it is pasted here, I mean, somewhere here. PSMA PET CT is done. We have taken the nuclear medicine opinion. They have considered, there are 2 opinions. One nuclear medicine physician has told that it can be given along with PSMA directed therapy like ADT and all. The other nuclear medicine physician has told it might not work because that is from other hospital. I don't have the exact reason why they did not opt for PSMA therapy, but I have taken an opinion.
Yeah, that's a very valid suggestion, actually. Yeah, I think that at this point, PSMA treatment may be appropriate choice, and reserving the rest of the treatment later line may be a good thought, actually. Yeah, because we have good
Yeah.
studies in castration-resistant prostate cancer where PSMA works better rather than going for unlabeled options. I think what Dr. Narendran said is a very good option. You can
Yes, yes,
try before thinking of all other options. Probably this options to be tried, I think.
yes.
And to the genetist experts here, any CDK12 mutation, any link with the neuroendocrine pathway, any link, or just it's a resistant pathway to the hormone mechanism, whether it's a resistant pathway, or it's just another pathway linked to the neuroendocrine pattern.
So mainly we see this CDK12 is a resistance mechanism developing as an alternative pathway as a resistance mechanism beyond the AR mutation alone, actually. So there are 2 different ways that it is generated, the resistance mechanism. One is within the AR gene itself, it is created the mutation so that the drug cannot able to bind. Then the another mechanism also, it's created a separate pathway, alternative bypass pathway, we will call it as, actually. So the CDK12 comes under the bypass pathway. It is created so that the resistance mechanism can still able to sustain. So that's why we need to go for the combination therapy rather than going for the single agent therapies.
Thank you, sir.
Thank you. I think Narendran, so to summarize, I think PSMA directed therapy may be the next line of choice. And definitely we can try combining abiraterone and PARP inhibitors in this particular case. Although we know that with the androgen resistant mutation there, whatever the response we are going to get, it's short-lived. That is the second option. Immunotherapy options are limited in trial setting. Cilimbrusen may pose some evidence for that. And once we exhaust all options, what are the androgen pathway inhibitor that can bypass this androgen receptor mutation? That also probably once Cilimbrusen post, that molecule can be considered at a later line of treatment. That's what we discussed.
Yeah.
Okay, sir.
Okay. Points are noted, sir. Thanks for
And
this.
yeah, and because platinum, because it's a HRR mutant is there, and we got good DFS with cabazitaxel and docetaxel. Weekly taxol carbo is also an option. And at this point of time, if a tissue diagnosis is possible, yes, definitely we can see any transformation is there, and we can see for other MSI, TMB, and a complete panel can be run on that if possible.
Fine, sir. Fine.
Okay, we'll go to the next case.
Yeah, please.
Thanks, Dr. Nagesh Ravdi. Thank you very much for
Thank
presenting.
you, sir. Next case is also mine only, sir.
Yeah, you can.
Can you move the slides to this second case, please?
Tamal, can you go to the next slide? Yeah.
Yeah.
Next slide, please.
Yeah, this is regarding a 51-year-old lady who was diagnosed to have carcinoma ovary stage 3C. Diagnosis was made in February 2024. Next slide, please. And initially she underwent laparotomy, but the procedure was abandoned further because of the omental caking. Following which she was treated with neoadjuvant chemotherapy with 6 cycles of paclitaxel and carboplatin, and then it was followed by cytoreduction. And the stage was YPT3C and the CRS1. But unfortunately, recurrence happened in April 2024. Though patient was advised BRCA testing at the initially, she did not undergo. And then at the recurrence, we started because of PFI is more than 10 months. We have rechallenged with Pacli Carbo. And after 6 cycles, we did a CECT chest abdomen, which has shown complete response.
Next slide.
Next slide, please. Yeah. So the imaging has shown complete response, and this time patient has undergone genetic testing, and the report says it is likely pathogenic. I just want to be doubly sure to further to go ahead with olaparib, whether it is from the database whether it is likely pathogenic or not. This particular mutation.
You can go to the NGS report, Tamal. Next slide. Yes. This is the hereditary gene panel what you have sent, right? It's from the blood hereditary gene panel, right?
Yes, sir. It is limited panel, sir.
Okay. Fine. Thank you, Nagesh. Actually, this explains actually BRCA. That's why the patient achieved again second CR also. So since second CR is there, and now we have a report BRCA1 positive, definitely adjuvant olaparib should be given in this case. And family should be tested for cascade testing should be done, and genetic counseling, cascade testing, and adjuvant olaparib. All three should be planned for this case. That's what my thought. Any extra input, any other feedback from others?
Sir, one quick question, sir. Actually, this is only germline testing done for BRCA1 and BRCA2.
Okay.
And is this testing has been done in the somatic testing also in the patient tissue sample?
In this case, it was not done. But does it add anything extra?
Yeah, sir. First thing is that we need to establish this the same mutation which is present in the patient tissue testing, which is the cascade testing we need to do, number one. But I would also at least we can do the ovarian cancer panel kind of testing or gynec panel kind of testing so that we can well establish the driver mutation. That will also open up the new treatment modality. For an example, it's the ovarian cancer. If it is a clear cell ovarian cancer, so then we will have the option of arid mutation with a PIK3 mutation. They will respond beautifully to immunotherapy. So like that, one option will open up when we are establishing the driver mutation. But the first bare minimum we need to do is the BRCA1, BRCA2 testing in the somatic panel testing, and followed by if we can do a small panel testing to find out the driver mutation, then the number of treatment options will be open up for the patient along with PD-L1 test.
Okay. So actually, Nageshwar Reddy, what Dr. Selambarasan is telling.
Yeah, I understood.
Yeah. So even if the patient have hereditary ovarian cancer, still BRCA,
Sporadic chances.
yeah, sporadic chances there, but it's rare, but still possible because olaparib for 2 years we are going to give, and it has a lot of toxicity. So if possible, probably somatic mutation also can be seen. I think that is the most important aspect. If possible, we can send BRCA on the tumor or HRD testing to see the functional loss of BRCA1 can be done. That option is definitely there.
Yeah.
But the chances are
it's
small.
not. Yeah, but for approval, it's not required. I think.
Yes. It's not required. You can go ahead, but whatever he said is a valid point.
Yes.
Anybody else have any other comments? I think this is a straight case. I think you can proceed with olaparib for 2 years and keep the follow. And if possible, do a tumor somatic testing to check whether it is there in the tumor also. Okay. Thanks, Nageshwar. So,
Thank you all for the suggestions.
thank you. Dr. Narendran, this is a straight case. I think so. Plan is to give adjuvant olaparib for 2 years. If possible, do run the tumor tissue for NGS testing, if possible. And genetic counseling, cascade testing should be done for this whole family members.
Okay.
Okay. So, Dr. Shraddha, I think she is not there. I will present the case for her. So she just messaged her inability to join. So it's a 59. She's a 59-year-old patient. Is a 59-year-old female, stage 4 endometrial cancer, good PS, no comorbidities, no family history. Next slide, please. Next slide, please. So 2023, she underwent Taxol Carbo. She was on maintenance letrozole, following which she received vaginal brachytherapy. Probably stage 4, she achieved complete remission. So probably local therapy also was included that time in November 23. Then reassessment was done in March 2024. Low volume disease was there. Then 2 months later, she had progressive disease for which she received palliative RT. Gemcite carbo was given. So till November 24, Gemcite carbo, then maintenance megestrol till March 2025. Then after that, she was given fulvestrant palbociclib. Probably by that time, they would have done the receptors. ERPR should have been positive. So fulvestrant palbociclib was given. 4 cycles she was given, then progressive disease. So she didn't respond to hormonal treatment. Next slide, please. So repeat, first biopsy was 2023. We can see ER was positive, Vimentin and CK7 was positive, adenocarcinoma, endometrial carcinoma. So last imaging September 2025, it's a progressive disease. Next slide, please. So we can go to the NGS and then come back to the, yes. Previous slide, please. So this is the NGS report. So this is the NGS is from the wall biopsy. NGS is done in 2023. This report on the paraffin blocks, probably they got the paraffin blocks and they did the NGS. So there are some clinical relevant mutation. One is the PIK3CA missense mutation is there. We can see VAF is almost 30%. Then PTEN mutation also is there. Frameshift deletion is there. VAF is almost 16%. ARID1A mutation is there. VAF is 27%, and TP53 mutation is there. VAF is 48%. So there are 4 mutations. Go back to the questions. Previous slide, please. Tamil, previous slide. Yeah. So PIK3CA actionability, role of aspirin in PIK3CA mutation. These are the question. And the plan was to ask, any role of lenvatinib was the question. So anybody wants to take this question? So my take, see, the patient has responded very well to chemotherapy regimen, and this is a endometrium. One thing is definitely we know pembrolizumab, lenvatinib, instead of only lenvatinib, pembro lenvatinib can be tried. There is a trial which showed significant DFS benefit is there as a second line treatment, I think. So definitely lenvatinib and pembrolizumab, irrespective of the PD-L1 status or MMR or TMB status, can be tried. That is one option which I can think. Only single agent lenvatinib, I'm not really sure in this particular case. PIK3CA pathway can be targeted. Yes, I think because VAF is 30%, I think PIK3CA pathway can be targeted because patient is having a ER positive is there, PIK3CA mutation is there. Probably we can hormones plus we can target the downstream pathway. That is a possibility is there, either exemestane, everolimus, but not in the first line. At a later line of treatment, definitely we can use molecules targeting the PIK3CA mutation. We'll see what molecular expert is telling. Role of aspirin in PIK3CA mutation, I think it's more defined in colorectal cancer, particularly PIK3CA mutation colorectal cancer, because aspirin acts on the cyclooxygenase pathway. There are plenty of trials that it helps in colorectal malignancy, but I don't think there is any positive trial in endometrial cancer. So at present, I'm not sure whether there is a role of aspirin in endometrial cancer. Definitely in colorectal cancer, PIK3CA mutation, there is a trials. We can add aspirin to those patients. These were my thoughts. We'll see what others are telling. Aparnadar, Dr. Silambarasan, your thoughts about this case?
Yeah, sir, let's go to the NGS report and decode the report one by one, sir. Yeah, sir, in this, there are 4 mutations we are having. PIK3 mutation, PTEN mutation, ARID mutation, and T53 mutation. So in this one, PIK3 mutation and ARID mutation always will come together as a co-mutations. In ovarian cancer and endometrial cancer, there is a subcategory of ovarian cancer and subcategory of endometrial cancer. This ARID mutation and PIK3 mutation will always comes together. In ovarian cancer, it's a ovarian clear cell carcinoma. They will come always together. In endometrial cancer, there is a particular subtype. This particular mutation will come together. Number 1. Number 2, ARID mutated breast cancer or ARID mutation, especially ovarian cancer and endometrial cancer, they will respond beautifully to immunotherapy. So if you are thinking about ARID mutation in ovarian cancer, ARID mutation in endometrial cancer, they will respond beautifully to immunotherapy. So that's what now the pembrolizumab with lenvatinib clinical trial coming into the picture very well. So 744 trial is the pembrolizumab with lenvatinib clinical trial in endometrial. So because of ARID mutation, you can very well trust that data and then you can start with the immunotherapy for this patient. That is the one of the finding I have find out. I'm collecting that paper, all those things. I will give it to the coordinator, which I have collected 4 papers. There is a special category of this ARID mutated endometrial cancer patient. The response rate to the endometrial cancer is almost 62%. ARID mutated category. 62% is the response, and then the patient, some of them even went on to achieve the complete CR also. So these are only case report, anecdotal evidences only available, but it's worthy of trying that anecdotal evidences to apply for our patient actually. Purely based on ARID mutation. Okay, whether PIK3 mutation will contribute to the clinical outcome? No. PIK3 mutation, even though it is present, because always ARID mutation and PIK3 mutation will come together as a co-mutation, but still immunotherapy combination it's worked. But in order to work, either you can use lenvatinib or you can even think about bevacizumab kind of treatment for the patient. So that's the take-home message I have for this patient, especially for the ARID mutation perspective only I'm thinking about. But only one challenge you are going to have is the P10 mutation. Whenever the P10 mutation is present, the patient will be immunologically cold in nature. The tumor microenvironment will be cold in nature. So that is the one angle we need to think that. But currently, as of now, I don't have any evidence of that when these three mutation will comes up, what is the impact of immunotherapy? But the other two mutation, immunotherapy with bevacizumab or lenvatinib, it will work. So only problem is the P10 mutation we need to have. Currently, we don't have any evidences for that. Even if you want to try, only the Keynote 744 trial is going to be helpful for us. That's it.
Thank you, Dr. Silverson. Anybody else having any thoughts? I think this case, pembro lenvatinib will be the next line. I think
What
particularly,
about
yes,
so after DO trial, so what is shown is in the proficient and deficient MMR, both it has shown benefit.
correct.
And since there is an additional thought of P10 being here, bringing immune cold environment, what about immunotherapy with PARP inhibitor here versus immunotherapy with lenvatinib?
Uh, I think see there is a trial showed pembro plus lenva irrespective of the MMR status, it benefits. But why you are thinking of PARP inhibitors in this particular case, Narendra?
Uh, because the theme of that trial itself.
Mm.
So when you combine the PARP inhibitor along with immunotherapy, even the cold it makes it hotter. So that is the concept. With that, they have designed the DO trial.
I
So
think all these things are in the testing. I think is there any definite evidence or any outcome has been measured in this particular scenario in P10 loss using PARP inhibitors and how it makes cold to hot? Any measurable outcome is there? Proven trial?
I'm not
No,
sure. Just wanted to
Okay, you want
explore.
explore. Okay, Silambaran and others,
no, sir.
what is the
No,
use
sir. There is
of
no
PARP
data for the
inhibitors?
P10 actually. PARP inhibitor usage in the P10 loss, especially I'm talking about P10 loss.
And not
In
in
this case,
P10 loss,
No, no,
but
no.
in this type
Uh,
of
what he is telling is converting cold into hot
uh,
environment, then making sure that Pembro acts in those
uh,
scenarios. Using PARP inhibitors to convert cold into hot. That's what Dr.
that
Narendra.
we don't have the data. That's what I told from the beginning. I were very little bit of skeptical. I were actually lean towards the DuoE trial also. But when I yesterday analyzed, decode the information between the keynote Pembro data and the DuoE data, there is no such data to prove me that the P10 mutation can be taken care by the DuoE trial. So that's what I have given the weightage, little bit weightage to the Pembro plus lenvatinib. Basically.
Okay. Can you both just brief the audience regarding the DOE trial?
Okay. Nagendran sir, can you go ahead, sir?
in the DOE trial, it's actually in the first line trial. So where they have given the chemotherapy along with immunotherapy, and as a maintenance continued the immunotherapy with PARP inhibitors.
Okay.
So what usually if it is a deficient MMR and proficient MMR, both they have seen in this trial. In both patients, this combination of maintenance therapy has shown a benefit. So their claim is that in the proficient MMR also, by combining the PARP inhibitor along with immunotherapy, it sensitizes even the cold disease, cold environment to the immunotherapy. That's what the trial
Good.
says.
But in
So
Keynote 775, the intent to treat patients all were benefited, irrespective of proficient and
Correct.
deficient, actually. In
Correct.
Keynote 775, it's not the benefit was not restricted only to deficient MMR. as
No,
per
here
my.
in this trial also all has benefited. Usually in the maintenance immunotherapy, in the previous trials where they combined the immunotherapy with the chemotherapy, those are the deficient MMR, that benefit was more. So, but
Okay.
here when you see that with this combination, both the deficient and the proficient MMR, they have shown a significant benefit.
Okay.
Sir,
In the
Nagendran sir, maybe I want to add one more point so that it will be easier for all of us to discuss on the same line. The DOE trial, initially they expose the patient with chemotherapy. Only the maintenance, they have given the PARP inhibitor along with the durvalumab to maintain it. So
yes.
it's a chemotherapy, it's converted the cold tumor into the hot tumor, not the PARP inhibitor. So that is where the challenge I had also yesterday when I analyzed this data. We
Okay.
expose this patient with the chemotherapy and expect that cold tumor will become hot tumor. We don't have any data for that same thing for the P10 mutation, basically. So that's the problem right now. But when I go into the keynote trial, I have safer data. So whether it's a MMR proficient or MMR deficient, all the patients they had exposed very well and they had the better data. So here you want to add one more chemotherapy into the picture, then only the question comes up. So for that perspective, I like both the data. 2E data is also good, but Pembro data also good, but Pembro data is exposed because without chemotherapy, you are getting the almost better benefit than the 2E trial. Okay. So
Okay.
I will leave the judgment to entire doctors as well as the treating physician to take the decision on that part.
So Pembro with lenvatinib, if you think in that aspect, Pembro with lenvatinib will be the next best option.
Next
So
best option.
only lenvatinib, I think there is a small trials, but I think Dr. Sharda was planning for only lenvatinib. But whatever the available data, it is less effective. It can be thought only if IO is contraindicated. Better to combine lenvatinib with Pembro, I think, in this particular case.
So our suggestion will be Pembro, better to combine Pembro with lenvatinib. Future lines, maybe since TP53 is there and other PIK3 pathways are there, may target the PIK3 pathway future line, or they can consider the chemo with bevacizumab also in future lines.
Yes, definitely.
Yes.
Definitely. I think in this case, fulvestrant, palbociclib already tried. So probably another hormones, exemestane, everolimus in future line can be tried.
Okay. Okay.
Okay. So we'll go to the next case. I think Narendra Neo case.
Next slide. This patient is a 71-year-old non-smoker. He was diagnosed with squamous cell carcinoma. Upfront surgery was done elsewhere. It has come a PT3N0 with lymphovascular invasion. No other risk factors are there, and margin is negative. So next slide. So he came to us. We are given a chemotherapy that's paclitaxel with carboplatin, and before this, since he's a non-smoker, we tested for he has they are tested outside itself for PDL1 and three mutations. So PDL1 the score was 1, and EGFR ALK ROS was negative. Other mutations was not tested, and we have started on 6 cycles of chemo with combined with immunotherapy, and then maintenance pembrolizumab was continued. After a third or fourth cycle of pembrolizumab, there was a loco-regional recurrence in the stump, and also in the port site recurrence was there, and he had two bone mets. So we have sent both the liquid. We have done a biopsy from the recurrent site, and we have sent for NGS, and we have sent a liquid biopsy also. And currently, you started on gemcitabine with carboplatin. Next slide. Next slide. Can you go to that
Next
NGS
slide.
report? The tissue. This is the tissue. One is tissue NGS, another is a liquid. This is a tissue NGS. So it shows a RAD54 mutation with a VAF of 23% and SMAD4 mutation with a VAF around 36%. And other CNV variants, the ALK copy number gain and BCL6 copy number gain. Next. And he had a EGFR copy number gain, FGFR copy number gain, Richter copy number gain, CDK4 copy number gain. The copy numbers in concern to this in this gains is the maximum copy number gain was with the BCL6 where the copy number was 15, and then with CDK4 the copy number was CDK4 it was 15. Others are less than 15. So this is the report. And next, this is MSI is low and HRD is negative. Next, liquid biopsy. Next slide. No,
Next.
again. Next.
Next. Next. Yeah, next. Yeah. Stop it.
So the liquid biopsy, whatever we have seen in the tissue, the RAD54L and SMAD4 is picked up in the liquid biopsy. So my questions is, we don't have any actionable. Can you go back to the question slide? We don't have any actionable mutations, targetable mutations here. So what are the mutations which is making the immune environment cold here? And if you see all these mutations, finally they activate either the RAS pathway or the PIK3 pathway or any other under cell cycle. That's what I could see here. Cell cycle progression was there, and then RAS pathway, PIK3 pathway, or apart from these three pathways, any other pathway comes into the picture here. Just wanted expert's opinion. And as of now, going with chemo with plus or minus ramucirumab. So next maybe an off-label option, whether if these three pathways are only activated, I may target the end like MEK inhibitor or mTAR inhibitor, and with CDK4 inhibitor, I can target off-label options at the final if there are other options are exhausted. So just wanted to know from the experts.
Thanks,
Let's
Martin.
go back to the NGS report, both the NGS reports. So first NGS report, right? So this one, RAD54L is present, SMAD4 is present. Rest of the copy number amplification, please forget about that copy number amplification. So all this copy number amplification or variation, it came as only just a resistance mechanism to the earlier treatment. So we cannot take any clinical decision with a copy number variation. So you minus off all the copy number variation first. Then you go to the liquid biopsy report. Please go to the liquid biopsy report.
Yes, stop it.
So this is the exact things also I want to highlight. When you look at the liquid biopsy report, the same two mutation only come up. There is no copy number variation came up in the liquid biopsy also. So these two mutation, one of them are going to be the driver mutation. Who is going to be the driver mutation first? RAD54L has been well established, or I have seen at least couple of two patients in MVR Cancer Center, RAD54L patient, foundation medicine have reported as a pathogenic, and it is one of the early lung cancer driving mutation. So among these two, RAD54L is the driver mutation, number one. Now how to go and take the clinical decision? So RAD54L comes under the category of a HRR pathway, homologous recombination pathway. So if you are decided go for the off-label kind of treatment, the only option left over for is PARP inhibitor. But there is not much evidence or even the case report to prove me that the PARP inhibitor have worked very well in the lung cancer patient with RAD54L. So RAD54L worst prognosis is the only prognostic indicator marker I have. Rest of the data I don't have. SMAD4 even worst, I don't have any other data. So only from this report I can conclude is that the driver mutation is RAD54L and it's a worst prognostic indicator. That's the only thing I have. So even if you want to try 1% of a drug, that 1% is present only in the PARP inhibitor, which is olaparib, rucaparib kind of thing. But in the lung cancer, you will not see much impact also because I don't have any evidence. This is the exact information I can say for you from this.
Dr. Silamarasan,
pathway.
this RAD, again, it's a DNA damage pathway, repair pathway. So platinum also should be like, because it's a lung,
Correct.
whether re-exposing, if there is a good platinum-free interval with this
Correct.
RAD, although we know PARP, there is not much data.
Yeah.
Re-challenging with platinum, if there is a good platinum-free interval, should be a good choice in this case.
Excellent suggestion, sir. Excellent suggestion. So that is the platinum-based therapy can be re-challenged because of the RAD54L, basically.
But actually, sir, he didn't have much of platinum sensitivity. While second or third month itself, he had a progression while on maintenance. Now also he's on gemcitabine carboplatin, but whatever the chest wall recurrence is not much of response to gem carbo.
Okay.
So
No,
so he,
I think better to go for the next docetaxel ramucirumab.
Mhm.
Probably instead of this molecular pathway, as he said, options are very limited. Probably shifting to docetaxel ramucirumab will be a better choice in this particular case rather than targeting the pathway, because so it's very complex mutations and a lot of copy number gains also is there, and limited options are there to target. As Dr. Silamarasan said, if platinum also is not sensitive, probably going for docetaxel ramucirumab will be a better choice. I think in this NGS is not contributory. That's what I think. Anybody else want to opine, please?
What about SMAD4? Is it falling into any other particular pathway, or it's act independence of any pathway?
So it's
Just
only the
wondering.
EMT process, sir. SMAD4 is well known for the EMT process, epithelial mesenchymal transition, which is a
Transition.
TGF
Okay.
beta followed by the SMAD4 will be the activator on that part of it. But we don't have any treatment modality for the same thing, sir. Both the mutation, what we are referring, we don't have even one or two paper publication as an anecdotal evidence to say that what kind of therapy may work. So unfortunately, in this case, molecular biology is not helping the patient in any way, except only one thing, prognostic indicator of SMART4. Sorry, this
Okay.
RAD54L, that's it. Rest of the
Okay.
molecular nature-wise treatment, no evidences for this case, sir. I have gone through completely on that part of it.
Okay. Okay. Thank you,
Okay.
sir.
Dr. Silamarasan, I just have one question, just based on my interest. If you see all the pathway in oncology, only 3 or 4 pathways. In fact, most of the time it's only 2 pathways. One is if you see the PIK3 AKT mTOR pathway, the other pathway is RAS, RAF, MEK, ERK pathway. These are the 2 predominant. Otherwise, JAK-STAT pathway or Notch pathway. Most of the pathways what we see is predominant comes to one of these things only. Is that it is how?
Yes, sir. Most of the pathways you are rightly said actually, either the PIK3 pathway or RAS-RAF signaling pathway or the DNA repair pathway. So these are the major 3 pathways will come. But what will make the treatment-wise difference is that combination of the gene and the combination of the treatment modality. For an example, even the PIK3 itself, we have different levels of PIK3 can be targeted. So one way alpelisib, another way is the AKT inhibitor, and the third way is the everolimus kind of inhibitor, and then the fourth line, the further down, is the CDK4/6 inhibitor. So it's all depends upon this decision, also depends upon the other mutation which we are having with the combination. So that's why it will become permutation combination, even though we are having 4 pathways as a standard pathway in most of the cancer, but the same treatment may not work in the same way we expected actually. Even though the pathway drugs options are available, it may not work. For an example, in this case itself, the straightforward information is RAD54L, DNA repair pathway, very well known. So can we use platinum-based therapy, or can we use PARP inhibitor? No, because there is no evidences or even no clinical trial to support the same data. So that's the only challenges we are having. Even though knowing the pathway is also very difficult to take the clinical decisions.
Okay, thanks, Dr. Silamarasan.
In
Thank
this
you.
mutation along with duplication, it's report in this report, no, the RAD54, there is a mutation along with if you see in the liquid biopsy. Can you comment on that, sir?
So that one is the duplication, is that particular region is getting duplicated. basically. So it's like, for an example, the particular portion of the nucleus is getting deleted, right? So this particular portion, which is 1093 to 1169, that position is 15 times repeated. It's like a tandem repeated. So that region is getting repeated. That means the amino acid, which is coating in that particular region, is repeated like a tandem repeats for 15 times. So that's what it is called, 15 duplication, basically.
Whether that is just a layman term, whether that is making it non-sensitive to platinum, whether we can take like that instead of
No, sir.
we see HRR pathway, usually they will be platinum sensitive. So
No, sir.
here
No.
no.
No, that's no, sir. Here we cannot take like that because
Okay.
this particular variant, because of that, whether it can be platinum sensitive, no, sir. We don't have any
Okay.
data to support the same thing. Only one thing I can say from here is RAD54, it's lost its function. So loss of RAD54L prognostically, it's a poor indicator. That's the only evidence we are having for this moment, sir.
Okay. Okay, sir. Thank you.
Thank you.
Thanks, Naridan. I think in your case, NGS is not contributory. Probably the predominant pathway is RAD, but still there's not much data. So probably then your next line, probably docetaxel ramucirumab will be a better choice. We'll go to the next case presentation. Dr. Suresh Kumar from Kaveri will present his case. Doctor, you are there? Dr. Suresh? Tamil, is Dr. Suresh is there?
Yes, sir. Dr. Suresh is there.
I'm not able to. Is Dr. Suresh? Okay. Can we go to the next case then? By that time, probably. So let's see whether Suresh. Tamil, can we go to the next case? So this will be Yogita from Vaidehi Hospital. So, Yogita?
Yes, sir.
Yes, Yogita. Go on with your case, please.
So this is an elderly gentleman, 60-year-old male, no significant comorbidities, non-smoker, no significant family history. He was diagnosed with adeno-CA lung upfront metastatic stage 4. He was diagnosed in 2021. PS is relatively preserved. He's a well-preserved individual. So he was treated outside. His EGFR was positive. So he was started on osimertinib in 2021 around May. And then after that, he has maintained response for close to around 2 years. Then after that, he was started on pemetrexed and carboplatin. Following that, again progress started on bevacizumab plus paclitaxel. And then he's progressed, and right now he's on gemcitabine plus carboplatin.
Next slide.
Yeah, I think we'll go to the NGS report. So basically, he's positive for the EGFR. He's negative for all the other things: ALF, BRAF, HER2, KRAS, MET, RET, ROS1. So we are considering starting him on amivantamab right now. But our question is, anything other than that could be done for him? Like there are some studies about re-challenging with a different molecule, like maybe erlotinib or gefitinib. Do we go with something like that? There are some cost issues also. So anything other than amivantamab can be done for this patient.
Okay.
This is a limited panel or it's a
It
like
is a
Garland?
it is a limited panel only, sir.
Okay. And this TP53 and other mutations is not there. Not
No, sir.
tested here. Or
No, sir, not it. No, it's not tested, sir.
only these only 8 mutation tested. We have to
Yes.
see how many mutations are tested here.
So, is there this biopsy is done now recently?
No,
Doctor?
sir, it is the old one, sir.
It's an old
not.
one.
Yes,
You
sir.
haven't repeated the biopsy.
We haven't repeated it, sir.
Okay. So I think in this case, which year it was done? 2025. Okay.
21, sir.
No, but sample received is 2025, it is written.
Just they done
No,
from
sir.
the old biopsy.
That is old biopsy only, sir. Now it was done again.
Okay. So this patient can you go back to the previous slide, starting slides? Patient was on osimertinib, right, initially?
He was, sir. He
He
was.
was on osimertinib, then progressed on osimertinib.
Yes.
So, have we done any biopsy recently after progression on osimertinib to see what is driving the resistance?
Recent biopsy is not done, sir.
Probably that is very important, I think, to see what is what is the driving mutation in this particular case. In this case, if you have run the NGS in the old biopsy, probably we don't know what is the driving mutation. Probably in this case, we need to run the new NGS, see what is the molecular pathway that is driving the progression of this particular patient. And based on that, only we can take a call. Yes, amivantamab, osimertinib resistant, probably Mariposa trial is there where you can add amivantamab plus lazertinib, both can be done as a post-osimertinib failure. But before that, probably we need to have a NGS panel, a new biopsy specimen, NGS, see the predominant molecular pathway, and then plan. Definitely, the amivantamab is option is there. Patient progressing on osimertinib, there is evidence for amivantamab plus lazertinib. Both can be combined, and it is superior based on Mariposa study. That's what my thought is. Let's see what others are telling.
Sir, anything
Even if
alternative to that, sir? Your call on re-challenging with the other TKIs.
There are few. See, if you see the few mutations, there are certain mutations which are resistant to osimertinib, but still you can try afatinib or dacometinib. So that is why what is the driving mutation we need to see. There are few studies which shows that you can, when combining certain mutations, when we are combining two TK also, it helps. So it is very important to see what is the driving mutation that is causing the progression. You are right. Post-osimertinib progression, few mutations, you can go back and try afatinib and dacometinib. There are, based on the mutation, we can select. So that is why it is very important to see go for a new biopsy, do a NGS, see what is the pathway that is causing the progression, then plan accordingly.
Okay. Okay, sir.
is there any difficulty here to doing biopsy here or tissue
He
yield or
wouldn't be, no, sir. He is not willing. Like the patient is not very willing. He's been extensively treated outside. He's come to us, so he's
Then
not very
liquid
willing
biopsy,
for
when
any.
you're
we
planning for
going to be
amivantamab, the
Oh,
cost is so high, we can go for liquid biopsy, right?
we can try that, sir.
That will
Yes.
be a good if a patient is not willing for a tissue diagnosis, because definitely at this point tumor shedding is going to be high. Patient is progressing. Most likely we'll have good circulating tumor cells. So even a good liquid biopsy should be fine in this case before you go for amivantamab. That's what will be my. Narendran was telling. Dr. Narendran was suggesting. Narendran, your
I
thoughts?
think, same, sir. If biopsy is not possible, at least liquid biopsy, and then instead of going for a costlier medicine, anyway, it will work because post osimertinib, irrespective of whatever it has worked. But at least a liquid biopsy may help them to know any other mutations which can dafatinib or other TK can work. So that is my suggestion, sir. At least liquid biopsy.
Okay. Okay, sir. Sure. We will take a call on that.
Okay.
Okay.
To
So
comment on the initial EGFR, that exon 19 deletion, it is a long segment which is not like a classical deletion. So it's a long segment, almost 5 or 6 amino acids were deleted and insertion happened there. So we can only think that from that report we can take. Otherwise, whatever it's now the resistant mechanism, we have to see.
Okay. Okay, sir.
okay. Fine. So I think in this case, liquid biopsy and see the driving mutation should be the most appropriate plan. Otherwise, amivantamab plus lazertinib should be
Yes,
a
got it.
option. That's not a problem.
Okay, sir. Sure. Thank you, sir. Thank you.
Okay, we'll go to the next case, please. Suresh, Dr. Suresh, you are there?
Yes, sir, I'm there.
Yes, Suresh. Over to you, Suresh. You can go on with your case.
So the patient is a 44-year-old female diagnosed as metastatic CA stomach. She presented with abdominal distension. DLAP was done. Omental mets was there. She also presented with gastric outlet obstruction. So feeding jejunostomy was done. So patient is they are very well-off patients. They already have some knowledge in molecular biology and all, because the patient's husband works in some molecular lab. And so we started the patient on FOLFOX. The treatment is ongoing. Only 2 cycles we have completed. So we did a molecular testing. So can you show the molecular reports? So this is a molecular report. So the molecular report from the tissue shows HER2 S310F mutation, so which is a HER2 mutation, and APC mutation as well. TMB was low, MSI is stable, and RAD51C promoter methylation is present. Can you show the next report? So we also did a liquid biopsy, which didn't show any targetable mutation. Claudin was done, which is 1+ in more than 95% of cells, which is taken as by definition negative. So Claudin 18.2 is negative. PDL1 CPS was 1%. Yeah. So we'll not go into the whole genome sequencing as of now. So this is the mutation, HER2 mutation. So usually for HER2 amplification, we give trastuzumab with chemotherapy, but HER2 mutation, TDXT is approved in later lines as per the literature. So this patient, how to proceed? I just want to inputs from others as well.
Okay.
Sir, can we
PDL
go back
was-
to the yearly report, sir? Just have a look at it, sir. Yearly report, the particular mutation. Yes, sir. Some more up. Some more up, sir. Yeah, this is the mutation, right? So ERBB2, which is HER2 mutated. Sir, if you look at that, this is very clear that any trastuzumab-based treatment will not be working. Even though if you are doing HER2, that's what they are saying that in HER2 only have the slight response. Basically, it's not because of the trastuzumab base, actually because of the chemo molecule which is binding to that actually. So S310F, it is present in the domain 2 of the extracellular domain. So if you imagine the receptor, HER2 receptor as a Y, actually, Y imagination, this particular S310F is it in the outside portion of the extracellular domain, outside portion. So that means this is a clear-cut evidence of both pertuzumab and trastuzumab resistance mechanism. So whatever the monoclonal antibody, either trastuzumab or pertuzumab, cannot able to bind to the extracellular domain because of this particular 310F mutation. First, number one. So in that case, what is the next best possible treatment option for this patient? There is a Summit clinical trial. The patient with a TKI, not monoclonal antibody, with a TKI, which is neratinib, or you can use tucatinib. So neratinib, tucatinib, pyrotinib, whichever the drug you are having option, the patient will respond beautifully to tucatinib or neratinib. So neratinib having the upper edge in 310F mutation than tucatinib. So my thinking is that you need to target the intracellular domain mutation, which is the tyrosine kinase domain region. So thereby you can overcome this resistance mechanism. No trastuzumab based treatment, which is trastuzumab, or it is Kadcyla, or it is Enhertu, will not have much impact like the TKI, which is neratinib or tucatinib. So that's the message, but I will share you that data also to you after the meeting. So 3 data I need to share to the organizer so that they will compile the data and then they will share with you later.
Okay,
Thanks,
so should
Samratha.
we combine it with chemotherapy, or can we use a single lane at the time of progression?
Okay, so if you want to combine for the chemotherapy, there is no way we can combine whenever the TKI or whenever we are giving with a combination therapy. We don't have any evidences for the chemotherapy combination. But if you want to go for off-label treatment, there is only one thing you can consider for the APC mutation is celecoxib, basically, which is approved, which is available data for the colorectal cancer, but not in the stomach cancer, basically. So APC mutation comes under the Wnt signaling pathway. So since it will be too off-label, I would still stick with only the niratinib or tucatinib based treatment.
Okay.
Here,
Doctor.
RAD51 promoter methylation, will it again activate the HRR pathway here? Will it, can we, my
Sir, it will
suggestion will
not
be,
affect, sir.
no, it will not, promoter methylation, functional
No, sir,
HRD.
it will not affect much on this part. No, sir, it will not affect much on this part. And also it will not contribute to any treatment selection also. So that gene promoter methylation also I gone through it. So only option right now we can prominently think for is the HER2 mutation we can consider for the patient treatment, basically.
Okay.
Dr. Suresh?
Yes, sir.
My thoughts for your cases is a first line treatment.
Yes, sir.
So we need to go for approved regimen. So first line, we go for HER2 based on IHC. Okay, whatever the TOGA trial, what we have is IHC. But we know that if IHC, in this case, if IHC done, if it's 3+ or FISH is positive, definitely, we need to think of adding trastuzumab, although we know there is a resistant pathway that is activated because we have evidence. This is a first line treatment. It's not second or third line. That is my. So most of the time in stomach, first line, we base our decision for HER2 directed treatment based on the IHC and TOGA trial. So IHC is important. Then PDL1, was it done in this case?
PDL1 is 1, sir.
PDL1 is 1. If it's PDL1
CPS
is
1.
If CPS is 1 or more than 1, definitely immunotherapy can be tried. One is CPS combined positive scare is 1 is borderline, but still they've included. If you think which cases definitely benefit, it's more than 5%. Okay, but still, if it's 1 or above 1%, definitely immunotherapy also can be added. So in this case, since it's a first line, we need to go with the evidence phase 3 or meta-analysis. So there is a phase 3 evidence. You need to do IHC, you need to do PDL1 testing and FOLFOX plus or minus immunotherapy, plus or minus trastuzumab based on a HER2 test. And since your Claudin IHC is negative, because I think it should be 2 or more to call it positive based on the spotlight study. So you cannot think of treatment based on Claudin report. So that is, we need to take it as negative. So since it's a first line, probably these are things we need to consider. Subsequent line probably is having a HER2 mutation based on the Destiny basket trial. Probably we can think of TDXD at a later lines of study, not upfront. This is what my thought, because it's a first line, you are starting FOLFOX. Probably we have good amount of data for first line. Probably we need to go for it. And probably later line, we should think of all these mutations.
Yes,
and
so
other.
usually in the presence of mutation, we say immunotherapy won't be much effective. So here in HER2 mutation, will immunotherapy will be effective? Does it warrant administration? Like, what are your thoughts, sir?
If HER2 mutation is, immunotherapy is less effective. That is right. Okay, but if it's HER2 is positive, IHC is 3+, definitely we can try trastuzumab and immunotherapy, but how much it is going to be effective, we don't know. It may be less, but we have data to support it.
Okay, sir.
Okay, we have data to support it. But definitely we know there is a resistant pathway. We are not going to expect the same benefit, but there is approved indication you can try based on your IHC and PDL1 report.
Okay, sir. So this patient also did whole genome sequencing from blood. They did themselves. So that was the report. So there shows a lot of mutations. So anything worth we should do further
Can you
for
go
this
back to
patient?
this slide? Can you go back to those reports? Can you show that report? Do they do HRD also here?
They didn't do HRD as a part of this test.
Okay. Whole genome. This
1% is sitting on the edge. CPS 1%. It is going to be difficult to discuss, but 1% above is indicated for immunotherapy. Since this patient has a lot of contacts, probably you need to go prepared actually. But 1 and above is what they said, but the exact benefit will be 5 and above.
This is not whole genome sequencing, right? This is the comprehensive genomic profile.
It's Garden 360. It's a comprehensive genomic profile.
The whole genome sequencing report is there here.
Yes, sir. I have attached. It's there behind.
It's Strand Life Sciences report, right?
So the Karkinos report.
Karkinos. Oh, okay. Sorry. Yeah.
Go down. Next slide. Come out of this Guardian 360. Go out. Go.
Page number 107, sir.
Okay. Too many profiling also is difficult, right? Stuff.
Yes, sir.
But can you throw some light how to read these reports, sir? Some experts.
Okay.
Because
Sir, one thing what I can say for you from this report is this page, current page you are seeing is only for pharmacogenomics. So you have to take this page currently you are seeing is for the pharmacogenomic purpose, whatever the drug you are going to take, the dose adjustment whether need to be done or not. For an example, the first drug, ivavirness, right? So if you are taking that one, because of the particular variant the patient is having, which is the third column, if you are looking at, because of that one, if you are taking that drug, they will have increased risk of adverse side effects, basically. So that is the only suggestion they are giving. So the entire page, whatever they are having is the SNP, single nucleotide polymorphism, which is the third number page, third number column you are seeing it out, right? So because of that one, the dose adjustment. But all this said and done, this is not at all going to be helpful in this case, because that is only well established for one drug or two drugs only, which is CYP gene along with DYPT gene, which is for 5-FU fluoride. That is only drug, or another one more drug option is there. For that purpose only, this pharmacogenomics currently we are having well good evidences. None of them are going to be useful, whatever you are currently seeing. So this page, if you go to the front page, some or a few more pages above, then you will have some other information which I can decode for you, how you can be able to help us with this.
I think
you need to go to the page number 3, basically. Page number 3 of total of 31 page.
previous page you go. Previous page you go.
Previous page number 3. Page number 2 and page number 3.
Tamil, go to the previous page.
Page number 2 and page number 3 of the report. You can come from page number 2 actually.
I think this is the report.
Yeah, this is page number 1. Yeah, yes. This is page number 2 actually. Sir, the problem with the whole exome sequencing or the whole genome sequencing is you will pick up a lot of mutation which we don't have, even whether it's a pathogenic or likely pathogenic, is there any evidences to support it? So that is where we are right now in the situation. For an example, the PHEX Plex gene, nobody knows what exactly this does, even in the cancer. Forget about this particular cancer, gastric cancer. I'm talking about the entire cancer. Nobody knows what is this PHEX gene will do. The same concept of the other gene, whichever you are seeing, the carrier gene, right? The bottom is all about is the carrier. whether one family to the another family. It's like a germline mutation passing from one generation to the next generation. So with this one, we cannot take any clinical decision out of it. So even though only one mutation, they are reported as a likely mutation, which is a PHEX gene, that gene also doesn't have any implication currently with even one or two evidences to support it's involved in the cancer. And what is the pathway involved in the cancer? Nobody knows. So whenever we don't have any information, we cannot even discuss about that particular mutation, sir. Really sorry that. So this is the current scenario about that particular report, actually. Okay.
Any other mutation? This is a final report. Any other next page?
No, sir. Everything is
No.
same, sir. This is a mitochondrial mutation. Even mitochondrial mutation also the same thing. Mitochondrial efficacy will be assessed because of this variant, basically. But still, this cannot be considered for even none of the treatment. This may be useful in the future, not now.
So this tissue biopsy has tissue NGS has picked up the head to mutation. Here it is not shedding much, so we are not seeing it in the. Can we take like that? This carcinose whole genome is not reported the head to mutation.
Bit of surprise because of that, actually, for me. Usually HER2 mutation, sometimes it will be picked up in the blood nicely. I need to check it out whether this testing has been done as a germline testing or somatic testing.
I think it's done as a germline.
If it is done for the germline testing, then it's very difficult to pick it up the
It's
point
germline.
mutations very, very rarely. So it's a germline testing. So with the germline testing, I'm surprised that HER2 mutation and all those things are not picked up. So most likely they may be missed out or it is not present in the blood sample. That's the way we can consider.
But why was germline testing done a whole
Exactly. That
genome
is my
testing?
The
surprise also.
patient did it themselves, sir.
Sir, may I add my opinion, sir? I'm Dr. Madhavi, genetic counselor. I'm
Yes,
not a
ma'am.
clinician. Yeah.
Tell me.
So I agreed absolutely with Dr. Silambarasan here that he has explained that this is a germline testing, and that these are all though there is a likely pathogenic variant. Now the one word which I would want Dr. Suresh to see is these are incidental findings, sir, because the patient has gone to do a whole genome sequencing. So they have not. So the first line is no relevant variations associated with the phenotype were identified. Meaning now, because she's a 44-year-old, as a geneticist, we would want to know if there are any germ, for example, specifically CDH1, for example, does she have any variant associated with cancer predisposition? Nothing was identified, but because of germline testing and it was a whole genome sequencing, incidental findings are reported. As Dr. Silambarasan said, none of the genes are actually anyway associated with cancer predisposition or anything. These are non-oncology associated conditions, many of which she's actually a carrier. There is one which, again, there is no clinical correlation. So all the information that you have are all incidental findings only, except the first list that you discussed, where sometimes the how they metabolize the drugs, if it is important, the clinician can take it into account. Otherwise, these are incidental findings. The last point I want to add here is that when they're doing whole genome sequencing, the depth of sequencing would not be very high as we go for somatic. So any kind of somatic variations will not be picked up, even if it is the blood sample. So this is definitely only germline. Because there is a young age of onset, and because again there is CDH1, there can be deletions on, copy number variations. The yield to detect copy number variations is a bit less in, on NGS. So if there is any MLPA test that can be done just to rule out that there are no copy number variations, you can suggest the test to them. That's the only thing that I want to, give my opinion here for her. That's it.
Can you go to Dr. Madhavi has brought in a very good point, actually. Thanks, Dr. Madhavi, about that X depth, basically. Can you go to the garden? I want to find out the ERBB2 S310F mutation at what X they identified. That is a very good point Dr. Madhavi have brought up. Thanks, Dr. Madhavi, on this point. Not here, sir. It has to go to the first page. Then only it will show the X depth, what depth they have identified. No. Next page. Report this one. And did they given the VAF percentage? Go to the X. Any depth have been reported? Go to the next page. Okay, so 2.1%. Okay, so this is the thing, sir. So 2.1% is already very low, but we don't have any evidences that what X they have identified. Like usually in the genome report, if you look at very carefully, that mutation, whatever we identify along with the VAF, they will be reporting what depth we identified. So if this mutation is identified beyond 150X, because in the whole genome sequencing or whole exome sequencing, they will be doing only up to 100x to 150x. They will be screening each gene only 100 times to 150 times. That's it, not more than that. Whereas in the somatic cancer, we need to screen minimum of 500x, minimum. So that means if this mutation has been identified beyond 150x, there is a chances that we have missed out in the testing which we have done in the Carcinos. So it's purely because of the X. So the test selection, the purpose, as Dr. Madhavi said, if it is only for CDH1 identification to rule out that it is a hereditary CDH1 positive gastric cancer, then the testing will be useful. But the entire whole exome sequencing need not to be done for that. CDH1 positivity testing can be done. So other than that, I didn't find out that test will be useful for any discussion in this forum currently, or even to take any clinical action about it. Okay.
And being a somatic, this VAF is how much we are happy with this VAF, sir, here.
Sir, cutoff, there is no cutoff, sir. When it comes to a driver mutation, if it is a driver mutation, like in this case, ERBB2 is a driver mutation, even 0.5 VAF percentage is considered as a good VAF. But there are some evidences are there. It has to be minimum of 2%. 2%. That is only applicable to rule out the chip versus the CHOP. Which is chip is a clonal hematopoiesis with intermittent potential.
No, yeah, this is tissue, this is tissue report.
Yeah, this is the tissue report. That's what I'm saying, that if it is in the liquid biopsy only, we need to consider about the VAF percentage, and that also 2%. It's the tissue, even 0.1%, you need to consider, especially the driver mutation, you need to consider as a driver mutation. So VAF is ruled out when it comes to the percentage in the tissue.
Okay. Thanks, Dr. Silambarasan. I think we'll go to the next case. So, in your Narendran, can you just summarize? Actually, a lot of discussion happened because
this patient, the presenter question is whether head-to mutation is there, whether we can go for TDXT upfront itself, so or any other head-to targets can be used. But as of now, the data for head-to mutation is not in the first line. So first line is based on the PDL1 and head-to IHC, and combining, if it is head-to IHC is positive and the PDL1 score is high, we combine with chemotherapy. But here, our suggestion is to consider for head-to new IHC. If it's positive, maybe we can add on trastuzumab, and CPS score is 1, so we can consider adding immunotherapy also. But the magnitude of benefit may not be as good as in other cases. In future line, based on this head-to-new mutation, either you can go for a Destiny based on a Destiny trial, and there also head-to-new has to be repeated. Again, in future line, based on the IHC only, you can choose. If IHC also, if it is positive only, the Destiny trial has shown they have tried. If IHC is negative, they are not used the TDXT. So whatever these head-to-new mutation based on the NGS, we can try in the later trials where later lines when all the other treatments are exhausted, either trastuzumab deruxtecan or TKS like neratinib, tucatinib, pyrotinib can be tried. Any other thing to add on, sir?
I think it's fine, Narendran. We'll go to the next case. Any other questions, Dr. Suresh? I think it was quite complicated. Anything else you want to ask? You were asking for cetuximab also. There is no data. I think that is based on the study where they tried cetuximab for head-to amplification case because it had head-to heterodimers with the EGFR. So inhibiting the EGFR may help. Again, these are all in later lines. I don't think any role of cetuximab upfront in first-line metastatic stomach cancer. Okay. Dr. Muthupandian? Dr. Muthumanikandan, you are there?
Yes, sir. Yes, sir.
Oh, sorry, Dr. Muthumanikandan, go over to you.
Yes, sir. So my patient is a 78-year-old male. So he's primarily a case of a CA lung, and along with that, he's also having a CA prostate. So initially, it was a metastatic NSCLC lung adenocarcinoma. So initially, he was diagnosed in 12th April 2021. So he is a known case of CAD and CVA, which is recovering. And so initial treatment history, so initially it's an EGFR positive NSCLC, so it's not alectinib actually. He was started on afatinib. So initially he was started on afatinib, and while on treatment, he has the PET-CT has been done. So on follow-up PET-CT, there was a response, but there was some suspicious prostate lesion. So biopsy has been done. It shows Gleason score grade 7. So RT has been given for 5 fractions. So PSA normalized after that. So after that, the prostate cancer was on follow. Afatinib was continued, and in till October 2022, progress. Then there was a progression. Then he was started on osimertinib. Liquid biopsy has been done, which shows T790M mutation. So till October 2024, he was on osimertinib. Then there is again a progression. So again, we have done a liver biopsy, which shows polydifferentiated adenocarcinoma. Then we have done a Gordon NGS, and it shows EGFR exon 19 deletion. Along with that, ALK fusion was also present. So then the patient was started on pemetrexed, carboplatin, and amivantamab. He received 4 cycles, and then there was a good response. After that, the patient has declined further IV chemo, and he has also developed an episode of CVA. And then now the CVA has been recovered, and he's recovering from CVA. Then because of the EGFR 19 deletion along with the ALK fusion, he was started on osimertinib with alectinib. So it will on April 2025. Then on August 2025, now presently, there is a PET-CT showed progressive disease, and we have done again we have done a PSMA PET also, because the PSA was rising, and the PSMA PET was done, which shows only osseous mets. Next slide. Next one. So this I already told that initial biopsy 2021 from lung, prostate, and then liver biopsy. And latest imaging PET-CT showed progressive disease, and PSMA showed PSA with osseous mets. And next slide. So next one. So in the question, so yeah, this is the NGS report, recent NGS report. I showed EGFR T790M mutation and EGFR C797S, and then EGFR exon 19 deletion, and along with that BRCA deletion is also there. This we have done now. It is a liquid biopsy now at present, August 2025. It shows this EGFR mutations along with the BRCA deletions was also there. Next slide. Yeah, the tumor mutation burden was less, and MSA was not high. MSA was low. So next one. Next. Next one. Next one. Can you go to previous one? Previous. Yeah. So the EGFR exon 19 deletion, it was 31.9%, and EGFR T790M mutation, it is 9.2%, and EGFR C797S, it is 5.5%. This is that percentage of on copy number which was present. Next one. Yes, sir. Actually, that's it, sir. So now the question is, what's the further line? How can we proceed? So we have planned for osimertinib to continue osimertinib with alectinib along with GnRH analog with bicalutamide. So my question is, next line, what can be offered, like datapotamab, which can be offered in this case?
Okay. Thanks. Thank you for presenting. It's a very interesting case. So to summarize, patient had EGFR and ALK fusion also. On top of it, had second malignancy, prostate cancer also is there.
Yes, sir.
And patient is presently on osimertinib and alectinib, but patient is progressing, but mainly it's a prostate metastasis that is progressing. Am I right?
Sir, no, sir. In PET scan, actually, it's a progressive disease, sir. And PSMA PET only bone lesion was there. lung lesion, it's also a progression.
So it's progressing on both sides.
Yes, sir. It's progressing on both sides, sir. So prostate we haven't addressed since the initial RT. After that, the PSA was normal, sir. It normalized after the initial RT. Now only it is raised.
Okay, and on top of it, patient has BRCA mutation also, right? BRCA2 mutation.
BRCA mutation also, it is from the liquid biopsy, sir.
It's from the liquid biopsy. Okay, okay. Any family history of malignancy is there?
No, sir. No family history, sir.
No family history. Okay, thank you. Thank you. It's a very interesting case. Let's hear from others. Anybody else want to start? Okay.
Sir, just go to the two reports. Before going to both the garden report, I want to ask one question. Alectinib, how long the response was there? Osimertinib with alectinib?
Sir, osimertinib which started in April 2025, sir, till August. That means 4 months, sir.
Okay, so that means clearly any ALK inhibitor is not helpful. Why I ask this question? Maybe it will be helpful for entire our group people also to discuss. The alectinib, the ALK mutation, whatever you have seen, is not the driver mutation. It is actually a resistance mechanism for the EGFR mutation, what you have seen.
Yes,
as
sir.
a temporary resistance mechanism. There are a lot of series of evidences are there. Whenever the EGFR treatment is going, the mechanism will come either through the other pathways like ALK or it will be MET. MET is more commonly discussed. When EGFR is there, MET will be coming as the bypass mutation. ALK also will come as a bypass mutation. That is what you are seen as a fusion over there. And when we acted upon that, whether the patient will get the benefit or not, the answer is no. That is what we have seen it in your case itself. From our self-learning case itself, it clearly shows whenever the EGFR mutation comes with one more driver mutation, it can be any driver mutation, that driver mutation need not to act upon because it will not work effectively. That is the first message we can take it from this case. Number one.
Okay.
Number two, if you look at the patient, the liquid biopsy, latest liquid biopsy we have developed, it is clearly shown the EGFR exon 19 deletion along with the T719M mutation present and the C797S mutation is present. One thing you need to observe from this case is whether it is a one side, whether both the mutations are present, which is cis or trans, we need to see. If it is both of them are cis, that means one side of the strand of the DNA, both the mutation of C79M is present and 797S mutation is present, then it is called cis mutation. If it is a trans mutation, then it is a clear-cut resistance mechanism that osimertinib will not work. If it is a cis mutation, you can continue osimertinib. If the patient have brain mets, is the patient have brain mets?
No, sir. No, sir.
No, brain mets. Okay. If it was brain mets, it was suggested that we need to double the dose of 80 to 160 basically. But in this case, we have to keep it. But your question is, what is the next beyond that therapy? One option it is coming to my mind is IM power 150 because EGFR progressed patient. If you look at your 2024 report, Garden 2024 report, you go to the PDL1 report, which you have PDL1 positive.
Yes, sir.
Can you go to that one? Two page before? PDL1 is positive. Just one page above. PDL1 positive.
Not this
And
report.
but the PDL1 is positive. I think you may know where exactly it is. In 2024.
After this report.
So this 2024 report.
Down.
Option
Yeah, down.
Next.
Yes, this one.
Previous.
So the PDL1 TPS score is 16%. So that means because of this one, you can consider about immunotherapy, which is ABCP regimen. Why ABCP regimen? The reason is two reasons are there. The patient have P53 mutation, which is 2773H mutation. So they will be responding beautifully to bevacizumab also. Another thing is that this patient have prostate also. So carboplatin platinum based therapy, I mean to say. BRCA mutation is also present. So platinum-based therapy will be a testamental whether the patient is going to respond or not. That you will come to know. So ABCP regimen would be an ideal choice, or you can give a good try because of EGFR progressed patient lung cancer. We are having a solid data with ABCP regimen. So that is one option. You can keep it in the mind.
Okay, okay.
And Pembro data is also available. Pembro data, keynote data is also available. EGFR positive progressed patients with a TKI treatment. There is a one data is also available for pembrolizumab. But first, my choice would be ABCP regimen because 4-drug regimen can taken care of various other mutation, which is you are seeing FGFR amplification is present in this case. When FGFR amplification is there, it's a little bit of resistance mechanism to immunotherapy. So chemo combinations will taken care of that part also. So from that angle, it will be helpful. Then if not, you can go for Pembro also. But the efficacy wise, ABCP, I feel that the data will be better than the Pembro data.
Okay. Thanks,
Here,
Dr.
patient has
Silambarasan.
received chemo, I think, paclitaxel along with amivantamab. One line of treatment was paclitaxel with
Yes.
amivantamab.
Yes, sir. PEM carbo, amivantamab, sir.
Pem carbo with amivantamab.
Yes, sir, after this.
Go with amivantamab.
Well, see, this patient already has CVA, so I think bevacizumab probably will be thinking twice for rechallenging and multiple times exposed. And age also, what is the age of this patient?
78, sir.
70. I don't think
That's
we'll
the
be
stage.
yeah, we'll be very soft in this patient, in this
Okay.
particular patient.
Yeah. Hi, sir.
So,
Kripa here. Nothing, sir. I mean, like, I just wanted to add probably the ALK fusion that you're seeing here is not the conventional EML4 ALK fusion. It's a SPINK2B ALK fusion that you're getting to see here, which can also be a driver. And also, if you're looking at a drug which can probably target both, brigatinib is an option. Brigatinib is one drug which acts on both EGFR and ALK. It's got action on both. So, rather than, I think the plan was, I think they're continuing on osimertinib plus alectinib. Is that right?
Yes, sir, it was the tentative plan, sir. Yes, sir.
Okay, so rather than do that, if you want to look at a drug which has got action on both, then brigatinib is one option that you could probably look at, because the ALK is something that's turned up now, right? It was not there on the previous NGS report, is it?
Actually, this is the previous report, sir. Previously, there was ALK was there, but
Okay.
current liquid biopsy NGS report, the ALK fusion was not there, sir.
Negative. The opposite, sir. Kripa, sir, it's opposite. That's what I said. It's a temporary mutation which was shown earlier as a resistance mechanism. It's not the driver mutation which is popped up.
Okay, fair enough. In that case, then fine. I thought probably that was the recent one. And also, you said it is a cis mutation. Is it a cis or a trans? As far as the C797S
How
mutation,
to find out whether cis or trans?
you'll have to discuss with them. If it's not been reported, you'll have to discuss with them and find out if it's actually a in cis position or in trans position. Has it been reported? Because usually, most commonly, that what you get to see is a cis mutation. Trans is pretty rare.
I don't know whether.
Has that been reported, or we could discuss that as well if that's not been reported?
Kripa, sir, that's the same question I asked actually. Unfortunately, in this report, it was not mentioned. Maybe we need to contact with the lab to find out. So that will decide us whether to continue with the same EGFR treatment or we need to switch over to some other treatment actually.
Yeah. So, cis means it's on the same allele, trans means it's on different alleles, meaning,
Exactly.
one side C797S and the T790M can be on different alleles. So that will probably tell us if you could use a first generation EGFR blocker in combination, or do we have to switch? And how, what about the prostate as well? How well controlled is the prostate?
Sir, prostate initially we have given RT, sir, 5 fraction SBR we have given, sir. After that, the PSA was controlled, but now recently the PSA is increasing, sir. And in PSMA PET, only the PSA avid bone mets only it's there, sir. Not other sites it's there.
Oh, so the PSA is increasing, so biochemical, and also you have radiological evidence of progression, is it?
Yes, sir. Yes, sir.
And what have you decided for the prostate?
The prostate for now we have tentatively told GnRH analog along with the bicalutamide for now, sir.
But why bicalutamide? Combined androgen blockade.
This patient is BRCA2 positive also, right?
Yes, the
The patient is progressing BRCA2 positive. Probably we can go to the next line. What about PARP inhibitors also in this particular patient? Because BRCA2 is positive and he's progressing. So that is another that line we haven't discussed at all for this patient.
That's also.
That's right.
So in this patient, I think, see, one thing we should consider is 78-year-old, multiple lines has been given. CVA is also there, and the patient has developed the resistance to osimertinib, and C797S is also positive. So, and patient is not willing for IV chemotherapy. That is the other clause we have in this particular patient. I think we need to think of oral. Probably cis or trans is important to decide whether we need to continue osimertinib or shift. And olaparib is one option, and probably next line other than calutite, probably we can go to abiraterone or enzalutamide. These are two options. What I can think in this particular case. Continue alectinib for this particular patient. Any point in changing to lorlatinib in this particular patient? Patient is progressed, and we don't know whether progression is because of ALK or EGFR mutation. Whether anybody would like to change alectinib to some other next line.
I think right now, sir, the current NGS has shown that there's no ALK. I mean, like, that's what I also tried asking him. But I think the initial NGS did show not the conventional EML4 ALK fusion, but a SPINK-B2 and an ALK fusion, which was picked up. But right now on the current NGS, it's in an EGFR exon 19 deletion with C797S mutation, which is probably the resistant mechanism here. So I think probably relevant to target the EGFR pathway, depending on, like we discussed earlier, whether it's cis or trans. And as far as the prostate is concerned, like you rightly pointed out, an androgen receptor pathway inhibitor with the PARP inhibitor combination would actually be preferable, given that there's a BRCA mutation as well. So I mean, like,
Dasatinib is a very good suggestion. Actually, it works on both. Probably we can consider that.
If cis is there, then you go for only this one dapotinib. What is that? The next generation TKI.
Sorry, I didn't get you.
If this is there, then we don't have much of options, right? If
trans mutation, based on that one, you need to combine with the first generation with like geftinib with osimertinib.
There we can combine osimertinib with first generation, or we can combine osimertinib with brigatinib. If cis is there, it may not work, right?
Yeah, correct. If it's a trans, probably we can combine. If cis is there, we need to think of other options.
So what is our suggestion if cis is there?
Yeah, first we need to get that information from the lab, whether it's a cis mutation or trans mutation. If it's a cis mutation, we need to move on for the next line of therapy with a different drug combination. So definitely ALK inhibitor is not going to play any good role over here. So either within the EGFR, first generation with the third generation, we need to think about combination, or we can even think about, because of the previous report PD-L1 positive, you can consider about immunotherapy. But as Arun sir mentioned that patient is 17-year-old, so bevacizumab, if you want to rule out, then pembrolizumab with some other combinations we need to think about.
The other thing is, if finances is not a constraint, then datopotamab deruxtecan also is an option.
Yes, sir. Datopotamab finance is not a constraint for this patient.
Yeah, if that's not a constraint, then Dato DXT, Astra has got the drug, but I mean, like, they've not yet officially launched it in India. But nevertheless, if cost is not a constraint, Dato DXT is an option.
And this patient CA prostate, apart from RT, any point of time ADT was done? Any form of ADT was done before?
No, sir. No, sir.
So Gleason score 7, should we go very aggressive on prostate? We can just do ADT alone here. Low burden disease.
No, but I think initially, what was the initial plan? What did they give? Is this CRPC or not? Okay.
It is not CRPC, it's castration sensitive, sir. Only RT was given to prostate. ADT was not done.
Okay, so straight away only RT was given without.
Because he was on burden of disease for lung was this one. So they just gave RT to prostate. So ADT was now only the ADT is being considered.
Yeah, so I think definitely combined androgen blockade will be better. I mean, like, rather than just plain ADT alone here, because anyway this is post progression, or I mean, like, after local therapy, after RT to the prostate. So I think, combined androgen blockade should be fine, meaning ADT plus an androgen receptor pathway inhibitor.
And for lung, as we decided, if it's trans, we can combine brigatinib with osimertinib. This you import.
No. See, the thing is, if you're using brigatinib, you don't have to combine. But the problem is right now you don't have an ALK mutation that's been picked up now.
So osimertinib with any other first generation AK if it is trans.
Correct.
Okay. If this is, you go for the fourth generation TK, which targets the C97.
Yeah, which is currently not only available in clinical trials. So
Okay, is there a clinical trial India running, sir?
No,
Any idea?
not that I'm aware of. Not that I'm aware of. Fourth generation EGFR TKI, ongoing trials, but not currently that are available in India. So the other option would be, if not, to go on to Dato-DXd, datopotamab deruxtecan.
Okay, sir.
Okay, sir.
Okay, sir. Thank you, sir.
Thank you. Thanks, Kripa. Thank you, Muthu Manigandan, for the case presentation. Probably the last case for the day. So it is a straightforward case. 62-year-old breast, CA breast, locally advanced. Next slide, please. So it's a triple negative subset. We gave EC followed by 9 cycles of paclitaxel weekly carboplatin, MRM, complete pathological response. RT was completed. Next slide. Because she's a triple negative subset. Next slide. We sent for hereditary breast cancer panel. Next slide. So next slide, please. So patient, it came positive for Fanconi's, actually, exon 14. It's a heterozygous variant, likely pathogenic. So this is the report. So what is the implication? Hereditary breast cancer panel I have sent. So Fanconi's also was done. So what is the chances of breast cancer here and how we go about? I think this is one of the DNA repair gene also. So what is the implication of this particular report to the patient and further treatment and to the family?
Any genetic counseling person is here, Dr. Madhavi, want to take it up this one?
Yes, sir. Yes.
Yeah,
So I thought someone else was speaking. So, sir, this, as you said, this is not a high penetrant genes like your BRCA1 and 2 specifically. The germline testing panel would include these FANC genes also. So we call them as susceptibility genes in one sense. They do have an increase that, I did go through the FANC gene associated with breast cancer. We tell that there is an elevated risk, but not a high risk for breast cancer. Only for breast cancer, it has been reported. So, but the percentages that we have for either PALB2 or BRCA or check that particular percentages, we would not know that what is the increase from a background population risk. But if you ask that was this variation the one associated or did it actually contribute to her breast cancer risk, we can say yes, because it has been reported. Heterozygous variations in FANC do increase, or there is an elevated risk for breast cancer. So secondly, now do we have to go for cascade testing? Yes, but only after genetic counseling, so that they understand that the risk is not as high as other genes. And two, for these genes, we do not have specific guidelines for other, high penetrant genes that, this should be like this. So based upon the family history, they can consider general screening can be considered. There are no very particular guidelines for this gene.
For this patient, what will be the screening for opposite side, or is it like BRCA1, BRCA2, the way we are screening MRI like that we need to do, or it will be regular breast cancer patient treated we'll be doing?
Regular, so there are no specific written guidelines for them, because there is, as we say, we use the word elevated risk, not high risk or even increased risk.
Okay. Thank you very much. This is the last case. Anybody else, any inputs?
As I just wanted to know the risk of, we know Fanconi anemia, the risk of being aplastic anemia later. So how about here, this patient, sir? What age or whether chance of aplastic anemia? I just wanted to know, because we are going to give chemotherapy here. whether the same gene has high risk for aplastic anemia.
Yeah, only thing is it's a heterozygous, so I'm not really sure how frequently we should screen this patient. Any other thoughts from anybody how to screen this patient for Fanconi's anemia? Whether presently patient is having hemoglobin all are normal. She tolerated chemotherapy well. No unusual myelosuppression I saw during the treatment plan. But how to follow up this patient is the question. Even when I checked in the literature also, I couldn't find much regarding the screening plan for these patients. They said the penetrance is variable and it's rare. So any similar experience to anybody regarding this particular gene? Okay. Dr. Madhavi, can you check and get back on this particular aspect regarding the screening for aplastic and Fanconi's anemia, how to screen?
Sure, sir. Sure, sir. Yes,
You
yes, yes.
can
Definitely.
also
Yeah.
verify and post in our group.
Sure, sir.
So,
Yes.
and anybody else have any thoughts on this particular mutation, please share your knowledge with us. Okay. So thank you all. I think busy weekend, all of you spared time and being here. I think some of you are in Jericare conference also, Bangalore. I think Kripa is there. Dr. Sharda also is in Bangalore. Many of you are attending. Still, you made sure you will be here for this particular meeting. Thank you very much. Have a great Sunday. Meet you soon, 2 weeks from now. Thank you. Thank you very much. I thank all the experts, Dr. Silambarasan, Dr. Madhavi Lata, Dr. Aparna Darsh. She's messaging her thoughts. I thank all the experts who have participated in this particular forum. Thanks, Narendran, for compiling the entire opinions and giving us every time after the molecular tumor board. Thank you very much. I thank all the presenters for coming here and presenting and sharing their case and improving our knowledge also. Thank you. Thank you very much. See you 2 weeks from now. Thank you very much.